Thank you, Don. I probably won't be as interesting as Elizabeth or as provocative as Darshak, but tough act to follow. And Don, thanks for the opportunity to participate. Anand Parekh, Chief Medical Advisor at the Bipartisan Policy Center. It's nice to talk about some of these concepts like nutrition and weight management and physical activity, not just when we're talking about primary and secondary prevention, but also tertiary prevention. I think that's what we're doing here. It's also nice to sort of focus on non-pharmacologic interventions. I think Darshak also alluded to this. Sometimes we feel like there's a double standard when you talk about pharmacologic interventions. Of course, there's tremendous sort of basic science research, clinical science research, a lot of money when it comes to pharmacologic interventions. There's the FDA that gives you sort of the safety and efficacy gold star. All of that information is very helpful to private and public payers. Non-pharmacologic interventions really don't have that. Don't have all the money in the basic sciences and the clinical sciences. What did Marcus say? There's no money in physical activity earlier this morning. And then there's no analogous sort of FDA stamp of safety and efficacy. And so I think what that leaves payers, you heard an example, both a private payer and a public payer, in somewhat of a lurch when it comes to, well, what is good enough in terms of safety? What is good enough in terms of efficacy? What's good enough in terms of cost effectiveness? And I think that makes it trickier. So I think this topic and the fact that you have a panel on this, I think, Don, is critical. I wanted to just take a couple of minutes before we get into discussion and talk about an effort at the Bipartisan Policy Center focused on this topic. We issued a report in 2012 called Lots to Lose, which focused on policy systems and environmental changes to tackle the obesity crisis. This was led by two former HHS secretaries, Donna Shalala and Mike Levitt, two agriculture secretaries, Dan Glickman and Ann Veneman. And there, that task force made recommendations that we really needed to focus from a provider perspective on competencies, so providers are competent in dealing with nutrition, physical activity, weight management related issues. And also that we need to focus on reimbursement policy for obesity prevention as well as treatment. And so we've been working with a cohort of partners, the Alliance for a Healthier Generation, American College of Sports Medicine, and a provider training work group of the Innovation Collaborative, formerly at the IOM, that Don co-chairs with Bill Dietz. And Bill will be tomorrow morning when you're here. He'll be summarizing sort of the work of developing core competencies to address, prevent, as well as treat obesity. What I wanted to just focus on is sort of the second part of our work, which is really convening payers to try to come up with some sort of agreement amongst public and private payers about how payers ought to cover obesity prevention and treatment interventions. And I think really the focus is to imagine if we could come up with some sort of standard benefit design. And so we've been convening really about a dozen private payers over the last couple of months, a dozen state and Medicaid directors, and I wanted to just let you know about some of the initial things that we've learned when it comes to the current coverage of obesity interventions in the general public. So this is now broader than just sort of cancer survivors. The first, and Don, you'll probably no surprise here, there's not a lot of transparency when it comes to the actual sort of benefit and coverage. You do have to do a lot of digging and search. Second, some of the common barriers that we hear when we talk about coverage of some of these interventions. One is member retention length and turnover, so the cycling of individuals coming and going in plans. Two, the existence of the return on investment, the evidence. We've talked about that today. The partnerships that are necessary, oftentimes with community partners that sometimes clinical entities don't necessarily have. The importance of senior leadership support. And fifth, sort of the importance of data tracking. A lot of the data that you need can't come from claims data, and you need electronic health record data and all. So there are a bunch of challenges when it comes to covering many of these things. And I think and one of the things that we also learned is really payers are really all over the map when it comes to coverage of many of these types of interventions, specifically non-pharmacologic and non-surgical interventions. So let's take intensive behavioral counseling as an example. This is, as Don mentioned, a U.S. Preventive Services Task Force recommendation, grade B. There's an ACA mandate that all commercial plans ought to cover this without any kind of cost sharing. But when you translate that evidence-based recommendation into benefit design, what we've learned from private payers is they're doing all sorts of things, from outsourcing obesity preventive services to health behavioral consulting companies. They're doing telephonic coaching. They're doing nutrition counseling. So there isn't really sort of one standard approach that's being taken. When you look at Medicaid fee-for-service, and you talk about this, and you talk to state Medicaid directors, so what we learn is there are about 8 states in the country that cover obesity-related preventive CPT codes. There are about 12 states that cover obesity-related behavioral consult codes, and about 15 states that cover all obesity-related nutritional consults. So most of the states in this country, in fact, in Medicaid fee-for-service, are not covering many of these services. So it really is sort of all across the map. So that's on the coverage standard benefit fee-for-service side. The next side to look at is sort of value-based metrics. So you've heard both from Elizabeth and Dershik that we're moving away from volume to a value-based reimbursement system. So then it begs the question, can we come up with value-based metrics? So i.e. population health targets, where you leave the interventions up to the providers. You sort of have a goal, and then you see if sort of providers can attain that goal. The problem there is sort of quality metrics, particularly for value-based metrics and obesity. So the National Quality Forum just recently did a preliminary environmental scan of existing quality measures, and while there are endorsed measures related to BMI screening and assessment, there really aren't any measures when it comes to addressing weight gain at the population or the plan level, and there are no patient-reported outcome measures as well. So that whole process of developing quality measures needs to happen. And when you think about what those metrics could look like, there's really no sort of consensus. So should we look at percent body weight loss? Should it be 3 to 5%? Should it be 5 to 7%? Should it be 5 to 10%? Should we look at obesity prevalence in terms of at the population level, obesity prevalence amongst the population coming down? That sounds great. It'd be great to have obesity prevalence measures and ACOs and Medicare Advantage star ratings. But the question is measurement. You need claims data as well as electronic health record data to track that. You need to risk adjust. How do you reward for change? Let's say a population does better, individuals do better, they reduce weight, but they don't get to sort of the 30 of BMI. How do you reward change that doesn't meet the target? So there are a lot of issues related to the actual metric when we talk about value-based payments. And the last part of what we're looking at is also sort of Medicare. So as many of you know, it's probably talked about earlier today, there is a national coverage determination for intensive behavioral therapy for obesity. So right now, Medicare covers, pays for visits to primary care physicians in a primary care setting, and they pay for intensive behavioral therapy, so weight management, nutrition, physical activity, once a week for a month, once every other week for 5 months. If there's a 3 kilogram weight loss, then once a month for 6 months. So it's fee for service, but there's a value-based hook. The problem with this sort of national coverage determination is that there's pretty low uptake, and there are a bunch of reasons for that, one being that it's limited to physicians, NPs and PAs, and not dietitians. So I think overall, as you look at Medicare, as you look at Medicaid, as you look at commercial plans, there are a wide variety of factors that are influencing whether these interventions are being covered. And when they are being covered, there may be barriers, and I think Don will probably talk about some of the barriers, some of the lessons learned from some of these services maybe in the discussion.